During this talk, I'd like to talk to you briefly about influenza vaccines, in particular, communicating science and policy in the face of an evolving understanding of an evolving pathogen. By way of introduction, influenza has been referred to by some as the Lion King of infectious disease. This is because it has an incredible mutation rate and therefore is truly a perpetually emerging disease. It has the potential to infect billions and can kill millions, and as such is the only known pathogen that is really capable of a truly global catastrophe because it has the potential to infect a huge percentage of the world's population in a very short time. Over the past 50 years, our primary public health tool against influenza has been vaccination. However, recently there has been an increased discussion and scrutiny of the vaccine effectiveness and a debate regarding the extent to which this vaccine prevents morbidity and mortality across all populations. In 2009, the Center for Infectious Disease Research and Policy, or CIDRAP, at the University of Minnesota, was provided a grant from the Sloan Foundation in support of the CIDRAP Comprehensive Influenza Vaccine Initiative, or CIVI. The goal of this project was to provide a comprehensive review of all aspects of the 2009-2010 pandemic H1N1 influenza vaccine preparedness and response. However, this ended up being not as straightforward as it might have seemed, and sometimes we were truly wandering lost in the woods. During the process, the CIVI team reviewed more than 12,000 articles, documents, transcripts, and notes dating back to 1936. We interviewed 88 experts in influenza vaccine research, development, and use, and convened 2 expert advisory group meetings in Washington, D.C. We found that the more we examined the current influenza vaccines, the more questions and lack of answers we identified, and found ourselves perpetually peeling back the proverbial onion. The final CIVI report took 3 years to complete, has 14 chapters, includes 505 unique references, 10 key findings, and 6 high-level recommendations. While all 10 of these key findings have implications at the science and society interface, this presentation is going to briefly explore 2 of these findings that have particular relevance. Key finding number 1. During some influenza seasons, vaccination offers substantially more protection for most of the population than being unvaccinated. However, influenza vaccine protection is markedly lower than for most routinely recommended vaccines, and as such is suboptimal. Key finding number 3 from the CIVI report was that in an effort to reduce influenza morbidity and mortality, over the last 3 decades, the Advisory Committee on Immunization Practices, or the ACIP, has expanded the populations recommended to receive influenza vaccine. These recommendations, however, often were based on professional judgment and not on scientifically sound data. This brief presentation will discuss these 2 key findings and the experience of the CIVI as a case study of the many challenges inherent in making and communicating public health policy in the face of uncertainty and continually evolving scientific understanding. The challenge here is basically one of communicating uncertainty and change. Or in other words, what we thought before, we don't think anymore. And this is based on new evidence and data and is part of the scientific process. And as such, science is self-correcting. We also believe that policy should be based on the most current and best understanding of the scientific evidence. We have some recent examples of such change in recommendation or policy based on new understanding of data and science. For example, changes in how we think about PSA level testing, and in particular, the ongoing debate regarding recommendations for mammograms. We also know that often, even when policy recommendations change, public opinion doesn't go along with that change, or at least not immediately. And we see things like this. Health in the news, where there's new recommendations for breast cancer screening meeting resistance, or even doctors resisting changes of new cancer screening guidelines, or expert agreement with the new mammogram guidelines are clouded by politics. So let's go back and remind ourselves of the key finding number 1 here and how this relates to changing policy recommendations. So again, what we found in the CIVI report was that during some influenza season, the vaccination offered more protection than being unvaccinated, but the vaccine protection was lower than for most of our routinely recommended vaccines. So how do we communicate, or how do people find out about the vaccine changes in policy or recommendations? Most people sit down and do what you and I would do and go to Google, and we Google flu vaccine and come up with almost 37 million results in almost merely a quarter of a minute. And what do we find? How do we wade through all of this information? What people are most likely concerned about is whether or not they should get a flu vaccine at all. And we'll come across quite a bit of information like this from the CDC, that shots aren't just for kids, but that we should all be getting our flu shot. At the same time, we run into information such as this, the truth about getting the flu shot. And the Mother Nature Network says that most medical professionals say that the advantages of the flu vaccine far outweigh any risks, but other professionals feel completely the opposite. Now what? And then there's things like this, 10 reasons why flu shots are more dangerous than the flu. How does one make sense of this? Well, often the 3 questions one might ask with these words, or perhaps in another way, is basically this. Are the vaccines safe? Are they effective? And do you really need one? For the purposes of this talk, we're going to focus on whether or not the vaccine is effective and how we message that to the public. If one goes to the Tacoma Pierce County Health Department, one would find this. How effective is the flu vaccine? 70 to 90% effective in healthy adults. Pretty good. Does it work? Well, at WebMD, I find how effective is the flu vaccine. Works pretty well. According to the CDC, flu vaccines reduce the odds of getting the flu by 70 to 90%. But wait, perhaps I'm a visual learner and I want to look at infographics, which are graphical representations of data and information. This was actually a project a student of mine did where she surveyed infographics that she found on the internet. And just to briefly show you, one of the things she found here is her examination of infographics regarding influenza vaccine effectiveness. And what you see, basically, it's all over the place, from 90% to 40 to 45%. How do we make sense of that? Probably the most accurate one on this page is the one that shows us 2 different levels of effectiveness, 70 to 90, 30 to 50, but even that isn't totally correct. And then, sites like this that don't even tell us what the effectiveness is, but basically tell us it doesn't work. Why doesn't the flu vaccine work? And then go on to discuss why the vaccine doesn't work. So where does this leave us? Well, pretty much with a challenging message and a changing message. Often, this is confusing. And in everyday life, this uncertainty or change is often heard of as unreliable or flip-flopping. Stephen Zare writes that because science involves producing knowledge about what was previously unknown, that uncertainty is normal and it is a necessary characteristic of our work. But the challenge, as we know, is how do we communicate this change and this uncertainty without appearing that we are unreliable or flip-floppers. And what ends up happening is this confusing message can be translated into something like this. The effectiveness of the flu vaccine raises more red flags. So the challenge, how do we best communicate this change or uncertainty? And how are we doing with influenza vaccine? December of 2010, this is what one would have found on the CDC's website. How effective is flu vaccine? 70 to 90% in healthy adults, similarly to what I showed you earlier on some of the other websites. A year later, in February of 2011, one would find this on the CDC's webpage. How effective is the flu vaccine? Well, I don't really know. This particular message from CDC provides no estimate of vaccine effectiveness and tries to explain this to the general public with different language. October 2011, later the fall of the same year, on the CDC's website for the public, again, no VE estimate. The paragraph here has a little bit different understanding and trying to communicate this a little bit differently, but again, no clear vaccine effectiveness estimate for someone who's looking for such a thing. Interestingly, the same month, October of 2011, on the CDC's website, if one looks under the recommendations for health professionals, we do find a vaccine effectiveness number of 50 to 70%. So no VE for the general public, but one for health professionals. February of 2013, the previous influenza season, if we look at the interim adjusted estimates of seasonal influenza effectiveness, it is 56% overall. And if one digs deeper into these data, there are actually different vaccine effectiveness for different age groups, some of actually much lower than 56%. So going back to the key finding that during some influenza seasons, we have more protection than not getting vaccinated, we still come back to this message that vaccine protection is lower than for most of our routinely recommendations. So how does one communicate that? Perhaps we simplify the message. And here is what Mayo Clinic says about flu shots. Your best bet for avoiding influenza. Getting a flu shot often protects you from coming down with the flu. And although the flu shot doesn't always provide total protection, it's worth getting. Perhaps that's about as good as we can get right now, if indeed we need sound bites. So, going along with the challenge of communicating the message is the challenge of making policy recommendations around this changing understanding of vaccine effectiveness. Jim Ogsbury has been quoted as saying, and I like this quote, that the world of science is methodological and linear and logical, but the world of public policy can be messy, disorderly, and chaotic. So again, how do we bring these two together? In 1990, Funtowitz and Ravitz wrote that policies can no longer be assumed to be based on scientific information that is endowed with a high degree of certainty. 1990 can no longer be assumed. I think we are kind of in the same place in 2013. They also stated that the guiding principle is that high quality does not require the elimination of uncertainty, but its effective management. So how do we effectively manage this? In an article in Nature by Rapley, they wrote that some of the tensions in the science policy interface stem from the public perceptions or from the nature of the scientific research itself. That the complexity of scientific research is often difficult to communicate to a lay audience, and that misunderstandings or apparent uncertainty in scientific research results can undermine the public trust in scientists and the policies that are built on scientific research. So going back to this public perception of our uncertainty or our flip-flopping can result in the public mistrust of science and of our policies. So how are we doing? Well, we end up with mistrust like this: the great flu shot controversy. The funny thing, they say, that there are no studies that prove that flu shots work, and that even the CDC doesn't provide an accurate estimate of flu shot effectiveness. Going back to the earlier CDC statements I showed you to the public, where there was no estimate of vaccine effectiveness, while the CDC was trying to be accurate, some interpreted that as a great flu shot controversy, conspiracy, and rambling jargon. On the other hand, Peter Sandman writes about that exact same effectiveness statement in the CDC and how health professionals were given an accurate 50 to 70% vaccine effectiveness, but the public was given nothing. And what Sandman writes is that this is a small example of officials not trusting the public, which is a very large risk communication problem, he says. So there are two sides to this question, two sides to this issue. We risk losing the public trust, but perhaps when policy officials do not trust the public, we end up in exactly the same place. The CDC, as one of its guidelines, states that it will base all public health decisions on the highest quality of scientific data, openly and objectively derived. And so it is from this that it will make its policy recommendations. And this leads us to key finding number 3, and that is this. In an effort to reduce influenza morbidity and mortality over the last 3 decades, the ACIP has expanded the populations recommended to receive influenza vaccine. These recommendations, however, often were based on professional judgment and not on scientifically sound data. So what are the recommendations and how have they changed over the years? This is just a brief table showing you how we have added the populations that are recommended to receive seasonal influenza immunization. And what you see is from 1960, when we began to add recommendations, year by year, over time, different populations were added until by 2010, this was a universally recommended vaccine. In other words, everyone in the population is recommended to receive influenza vaccine. The movement towards this universal vaccine recommendation came as a result of several ACIP meetings. And in 2005, prior to the universal recommendation, the Influenza Working Group identified several gaps in knowledge for expanding this vaccination recommendation. And those gaps included knowledge about the effectiveness in the population over 65 years of age, indirect benefits to people who are not at increased risk or complications from influenza infection, the cost effectiveness, and the safety of repeated vaccination. In 2006, they stated that several critical factors must be assessed before changing current recommendations and advancing towards this universal policy. However, a year later, in 2007, they stated that no one in the group felt there were any critical data gaps. When we went back and reviewed the ACIP documents, no data were presented at ACIP meetings or in any other records from 1999 to 2011 that addressed the gaps that had been noticed previously prior to the expansion of the recommendation. In our review of the 2010 ACIP statement, the CIVI group found 30 instances where authors did not apply current standards of scientific rigor to their analysis or did not cite the relevant work. It was found that the ACIP statement overestimated vaccine effectiveness and that the statement includes studies in which the results were not reported accurately. So where does this leave us? How can the CDC base all public health decisions on the highest quality of scientific data when at the same time the world of science, while linear and logical, has to work within the world of public policy that is messy, disorderly, and chaotic? Where does this leave us when well-established scientific ideas are not easily abandoned, as we think about our new understanding of less than optimal influenza vaccine efficacy? Where does this leave us when public health is messy and public policy is messy? And knowing that this messiness, this uncertainty, or this change of our understanding can lead to loss in the public's trust. Where does this leave us? Well, with many more questions, and they're difficult ones. How can science be useful to our society even when the evidence is ambiguous? And how do we effectively communicate change? What's the role and responsibility of policymakers to communicate uncertainty, change, ambiguity? What is the weight of the evidence required to change policy recommendations? And even what counts as evidence? I wish I had answers to those questions. I don't. But I think we need to continue building opportunities for scientists, policymakers, the media, social scientists, and more to engage in meaningful dialogue around these issues. We need to continue to educate scientists and non-scientists as well. This goes both ways. And do the best that we can to ensure that our policy recommendations are based on the best and most currently available data. Or as John Adams said, facts are stubborn things. Whatever may be our wishes, our inclinations, or the dictates of our passion, they cannot alter the state of the facts and the evidence. Thank you.